This episode was recorded in Q1 2026. The information provided in this podcast is for educational and informational purposes only. The views and opinions expressed by hosts and their guests are their own and do not necessarily reflect those of the Irish College of GPs. By listening to this podcast, you acknowledge that no party is liable for any direct or indirect consequences resulting from the use of the information provided. More information can be found in the show notes or at irishcollegeofgps.ie.
Mirtazapine 7.5 to 15 milligrams is really good for sleep issues, and that's because of the histamine effect. But if you go higher, you get more of a noradrenergic effect, and it can counterbalance the good sleep that they've got at the lower doses. So it's not the higher dose you go on mirtazapine, you get better sleep. It can actually worsen sleep, so it's good to be aware of that as well.
Hello and welcome to the GP podcast from the Irish College of GPs with me, Dr. John Maher. Today I'm continuing my conversation on managing depression in primary care with Dr. Aoife O'Sullivan and Dr. Brian Osborne, based on their 2023 Quick Reference Guide on Managing Depression in Primary Care.
My name is Dr. Aoife O'Sullivan. I'm a GP. I work in Cork, and then I also work with the Irish College of GPs as a clinical lead in mental health.
My name is Brian Osborne. I'm a GP in Galway City, and I'm an Assistant Medical Director with the Irish College of GPs.
This is part 2 of our conversation, so if you haven't had a chance to listen to part 1 yet, please start there. It's also available now in the show feed. We wrapped up part 1 with a discussion of the first link in the Jump To box on the front page of the Quick Reference Guide, which was talk therapy options. Today we cover the remaining 3 quick links on the front page, which bring the reader to sections on medication considerations, switching medications, and referral to secondary care. We wrap up today with a discussion around potential audit and practice improvement initiatives in this area. As a reminder, I've included a link to the Quick Reference Guide in the show notes, and you may find it useful to have this to hand as you listen. I've also included links to other resources mentioned today and chapter markers as usual. Brian began today by providing an approach to commencing medication for depression.
So if you've decided that someone needs medication, I think there's really good, the guide is a really good resource for this. I think we all know it's not just a case of here's your SSRI and out the door. You're obviously going to explain to people what the medication is, what it does, regarding the potential side effects. Generally, in my practice, and I think it's referenced in the guideline, you check in with them after 2 weeks to see how they're getting on, if there's any improvement. I generally tell them, I think it's 4 weeks is usually how long it takes for an SSRI to start working. I tell patients 4 to 6 weeks to give them a little bit more time, because some can be a bit reticent, in the first few days, even taking it. So I generally check in with people at 2 weeks, 4 weeks, plus or minus 6 weeks, depending on how things are. The first line treatment would be SSRIs, and it's as lots of us know, it's sertraline and escitalopram will be the common ones that we prescribe in our practice, and I think lots of people will see good results with those. The fluoxetines and paroxetines are mentioned in the guide. For me, they're not prescribed as commonly anymore. I still think some people still use them, but we don't use it very much in our practice personally. If they aren't working, there are second line options. Mirtazapine, I think, is a really nice medication. It obviously has its side effects of somnolence and weight gain, but in particular for the depressed person where appetite is an issue and poor sleep is an issue, mirtazapine can be a really good one. And mirtazapine 7.5 to 15 milligrams is really good for sleep issues. If you go higher, they can get more of and that's because of the histamine effect. But if you go higher, you get more of a noradrenergic effect, and it can be it can counterbalance the good sleep that they've got at the lower doses. So it's not the higher dose you go on mirtazapine, you get better sleep. It can actually worsen sleep. So it's good to be aware of that as well. And then you've got other medications like venlafaxine and duloxetine, second line. Medications, maybe Aoife has a bit more experience with the agomolodine and the vortioxetine. I haven't prescribed those very often myself. Some patients I have, but I generally go with the SSRIs, and if we're not getting effects from those, then I go on to the mirtazapine or the venlafaxine, duloxetine. Aoife, would you be similar to that?
Absolutely, yeah. I'd be the same, Brian, really, with the first line of the sertraline and the escitalopram, or Lexapro, we're probably used to calling it. I'm working with younger people. I do actually use agomelatine and vortioxetine as probably slightly second line options for different reasons. One would be the sexual side effect can be an issue, particularly with young men, and you have a slightly lower risk. So if they don't like or won't tolerate the sertraline, or more importantly, don't take it, so you're prescribing it, but it's not actually being taken, it can be useful to look at something like valdoxin, agomelatine as an option. It also helps with sleep, so it can be helpful that way. It starts with 25 milligrams at night, titrating up to 50 milligrams at night, and can be helpful with sleep. And for those with sexual side effects with the other SSRIs, it can be worth trying. You do need to check LFTs before starting it, and again after 6 weeks, which can be off-putting because obviously you don't need to do that with other medications. But if you don't mind doing that, it's a nice option. The vortioxetine, we're starting to prescribe a little more now. It was a lot more expensive, was one of the downsides to it. But I think that's starting to balance out a little bit. And the lower risk of sexual side effects with young men, again, sometimes for some patients will make it a good second line option. But no, for first line, same as yourself, the sertraline and the escitalopram would be still our first line options.
Thanks for that, Aoife. Brian, just to emphasize there, going back a step to the mirtazapine for a moment, and you mentioned about the sleep. What was that threshold that you say for effective sleep? Did you say 7.5?
7.5 to 15.
To 15, okay.
To 15. They're the best for sleep. As you go to the higher doses, the noradrenergic effects kick in more than the antihistamine effects. So so you'll get it will actually could potentially worsen sleep.
Understood. Okay, that's very useful as well. Okay, great. And then Aoife, you mentioned the agomelatine and the need to do pre-commencement LFTs and then follow-up LFTs, which just brings to mind the idea of bloods, and then that brings to mind the idea of keeping a broad mind, basically, with all of these consultations. And I know that sounds really obvious, but it is important, isn't it, to also consider other physical health conditions which could result in a mental health presentation.
Absolutely, that while we don't need to do bloods to make a diagnosis of depression, it's not a requirement in any way. At the same time, maybe keeping it in the back of your mind, do I need to be on the lookout here for something like an underactive thyroid, for maybe vitamin B12 deficiencies, vitamin D deficiency? We can probably, to be honest, I assume that's ubiquitous in Ireland in winter. I tell everybody to go on their vitamin D supplement, and that can help with mood as well. But like everything else, we do need to remember that there are other illnesses that can have low mood as part of them, such as hypothyroidism or low B12, and it's important to check for those as well.
And John, to be honest, I check for most patients who come in with a low mood first presentation. I probably do check their bloods. It may not be completely necessary, but I think both as just a general screen and for a safety netting for yourself as a doctor, I think it's a reasonable thing. Like Aoife said, the thyroid, the hematimics, the check for diabetes, all these, the kind of the routine bloods that we do from day to day. I think it's a completely reasonable thing to do.
And I'm still in this, the pharmacology section of the GPU. And, once, at the end of that, like which medication options you have, there's a section on poor response. And, whether you decide to do bloods initially or not, if there is a poor response, I guess that may be another opportunity to take a step back and reconsider whether the diagnosis is the appropriate one. I think would be fair to say as well, wouldn't it? So if there is a poor response, after, you've given a trial, you may have titrated, you're not seeing much of a change, what next?
So a few things, I suppose. First of all, is making sure that the patient did take the medications, that there weren't things like side effects that stop them from taking it. So if you're happy that the patient has taken the medication as prescribed, and also that they've been moving, this is a big one for me. I think SSRIs, if somebody is lying in bed all day, what they call now bed rotting is the new term for that, are turning day into night, that really there isn't a magic pill that's going to fix that. It's really important to make sure that in addition to taking medication, that they also looked at all that really good advice you gave in the first visit about getting regular exercise, diet, nutrition, good sleep patterns, that the patient did, go ahead. And there's no magic pill is going to fix those things. So I would often explain to patients that these medications help your serotonin, and we also produce serotonin when we move, when we exercise. So just like that park run we talked about earlier, or it could just be a walk. It doesn't have to be anything too fancy, to make sure that you've been moving as well, so that we increase our natural production of serotonin. But if all of those things, those boxes have been ticked, and you and the patient both feel that this medication is not working for them, then it's absolutely reasonable to think about changing to a second line medication. To do this, I almost always go back to the GPU and check that next yellow box on the first page that brings you down to the medication section and changing medication, because it can be really hard to remember which SSRIs can you stop quickly, which ones take longer, and how do you make that changeover. So highly recommend doing a quick check back and trying your second line medication. And then I think, if that's still not working, you're probably looking at referral really to secondary care after that. But yeah, a shout out to that jump to section on that first page of the GPU.
And also, Aoife, a shout out to the actual layout of that switching box, which is actually well laid out and easy to follow. I'm sure some listeners will feel my pain when I bring to mind some of the charts that are available, where every possible kind of antidepressant is shown on the column and in the row, and you have to find the row and then find the column. And I've broken out in a sweat more than once with a patient looking at me trying to find the appropriate little box. So it's in the GPU, it's very clear, it's easy to read, and it's quick. So that's really useful too.
Can I just
there? Yeah, sorry, Brian. Go
John,
ahead.
can I just say, Aoife said she goes to it most times. I go to it every time. So Aoife obviously has much better memory than me.
Yeah, I agree. Absolutely. And Aoife, as you said, if things are not working out, then we think about the option of secondary care, which brings us to our fourth and final hyperlink from that front page of the GPU. Brian, could you maybe go through some of the criteria that you have in your head around referral?
So referrals, sometimes someone you see them for the first time and they might need a referral straight away. If you think someone has a severe depression and they're actively suicidal, or have an ongoing death wish, they might have had a past history of depression before, they might have been linked with services before, that would be straight away referral to me. Also, if there's a failure to respond to treatment, and generally a failure to respond within a period of around 3 months, that would be another reason to refer. Then there's people who are worsening, so you might see them initially, and you think you can contain them in primary care, with linking them with the services that we've outlined before, treating them with medication, highlighting the lifestyle issues. But if they're worsening and their symptoms are changing, and they go from reasonably stable to suddenly a sudden deterioration, that would be another reason where I would be referring to secondary care. Now, of course, that does bring us into the problems of referring to secondary care, because it's not just a case of lifting a phone and they're seen straight away. So, you do need to, I suppose, if sometimes people will have to go to the accident emergency department straight away. That's probably the worst place that they can go. But for the safety of the person and the safety of you as a GP and as a healthcare professional, sometimes that's the only option. Different areas have different services. There used to be a hotline in Galway that you could ring. That's gone now. So there's no e-referrals to psychiatry. Sometimes it's getting on the phone to the CPN, as they used to be called, or community mental health nurses, they're called now, and trying to link people in with the appropriate services as soon as possible. If not, it's a standard referral letter. But they're the referrals that I would see myself doing. But to be honest, the vast majority of patients with depression are managed in general practice and primary care.
Great. And, I suppose you allude to the more serious and significant presentations there, Brian, and sometimes needing to send people to the emergency department. And that also, in the background there, you also have the Mental Health Act and the potential for involuntary admission, which we're not going to cover as part of this, but we do have another podcast in the works at the moment around involuntary admission, so we won't cover that there. But obviously, it goes without saying that you have to use your clinical acumen for what's a crisis and what requires emergent measures now. So I think we've said enough there. So Aoife, sorry, go ahead.
Just another thing that's, I suppose, available now that maybe wasn't, because I don't think it's in the GPU, but is the Suicide Crisis Assessment Nurse, or that's acronym there is a SCAN nurse. So this is a service that's been rolling out around the country over the past couple of years. And there may, again, I acknowledge there's huge geographical variation. There may or may not be a SCAN nurse in your area, but in some areas the service is well established. And when you have somebody who has suicidal ideation, you want to refer them, but you don't want to wait, 6 or 12 weeks for an outpatient appointment. But at the same time, that they don't maybe need to go to A&E and sit in A&E all night either. Where the SCAN nurse is available, you can contact the SCAN nurse as a GP by phone, and they will endeavour to see the patient within 72 hours in the community, so not in the hospital. So if that's, and again, I know not all areas will have that cover, but if you have that cover, it can be a very useful service to be aware of.
Okay, thank you, Aoife. So there are 4 hyperlinks on that front page, and hopefully listeners will agree that, this is all super clinically relevant aspects of the GPU and kind of gets to the core of what might be needed during a patient assessment in front of you. And it's all quite easy to read and quick to review. The final part of the GPU then is around the clinical audit. And, having listened to both of you now, I'm thinking about my own practice, and, there's always ways to improve, but there are ample opportunities, I guess, in terms of depression, where one could formulate a straightforward audit that could shine a light on one's practice. And there are numerous examples, Brian, on page 13 of the GPU of examples of clinical audits that somebody could undertake.
Yeah, there's various examples, John, like from examples around the physical examination. Where did you use the PHQ-9? If medication was prescribed, was it within the scope of guidelines? Was there a review within the first couple of weeks of prescribing that medication? Whether psychological therapies were recommended, or if the patient was referred to any talk therapies. And also around referrals, how many patients have you seen? How many patients needed to be referred? So there's lots of different examples of audit, and especially under the new Medical Council framework for professional competence, I think it's a really good resource to have for your audit, because it counts as 10 points or 10 credits towards your CPD.
Great. And one of the things, Aoife, that I suppose struck me from going through the clinical audit part is some of the ones that are given as examples would also probably be useful as a starting point to possibly and potentially create some drop-down templates in your practice software to maybe focus when you do see a patient and you want to capture some of the pertinent information, if it hasn't all come out over the natural course of the conversation, you can do a little bit of mopping up if you have a template in front of you.
Yeah, I think having a template is really useful aid to memory, because we all, have experience. I think as patients experience it too. They walk out the door and say, "Oh, I never told the doctor this point." But as doctors, sometimes when the patient walks out the door, you'll think, "Oh gosh, I never asked them about this really pertinent." It happens from all sides. And I suppose the other thing is that could sort of feed into a quality improvement project, because that's also allowed, we think of the traditional audit, but now that's expanded. So you can look at doing that as a practice improvement or a quality improvement project. So it can be useful in our very time restricted space to have that little reminder of questions, and it can also go towards a quality improvement project within your practice. Because as Brian already mentioned, is it something like 80 to 90% of patients with depression are managed entirely within general practice. They never get referred on to secondary care, and this is not resourced work. So being able to qualify it and quantify it as part of your audit can be really useful.
Thanks again to you both for all your time with the GPU, and I think I've emphasised enough now how valuable I find this in my own practice. So thank you to you both. It's really useful. Brian, would you like to send us off with a take-home message?
Well, I think, John, depression is something that's very common. It's something that all GPs are going to see every week. the majority of cases are managed in general practice and primary care, but it needs time. And that, we have to acknowledge that it's difficult and it needs time. We can signpost to lots of different services that we've highlighted here that Aoife outlined earlier. And then there's a very small minority of cases that we need input from our secondary care colleagues.
Many thanks again to Dr. Aoife O'Sullivan and Dr. Brian Osborne for taking the time to speak to me today. And don't forget to check the show notes for chapter markers and links to resources. If you're enjoying the GP podcast, please subscribe to the show wherever you get your podcasts so you don't miss an episode. And while you're there, you might consider leaving a review on Apple iTunes or wherever you get your podcasts to help others discover the show. If you've any comments or feedback, or indeed suggestions for future episodes, we'd be delighted to hear from you. You can contact us at podcast@icgp.ie. And that's it for today. Many thanks again for listening, and until next time, take care.